within fascia. And I will just also bring your attention to the neuropeptides, because Helena was talking about those, and I think it's really important to understand that these are involved in this critical efferent function. So when there is a nociceptive event coming off the peripheral tissue, yes, there will be volleys of signals going towards the dorsal horn. Before they get to the dorsal horn, they come to this structure, dorsal ganglion, which, as I showed you before, has cell bodies. And this ganglion has cell bodies for C fibers and good 4 fibers. It'll produce increased amounts of neuropeptides like substance P, CGRP, somatostatin. This will increase the volley into the wide dendritic range neuron, which we'll talk about in a moment, in the dorsal horn. But as it turns out, 90% of these biochemicals are actually being transported back down the axon to be released into the peripheral tissue. Okay? They're actually, as I said, they're involved in the initial reaction to maintenance of the tissue injury. But we also know that these biochemical reactions run awry in certain chronic pain states like complex regional pain syndrome. And as we are identifying in active myofascial trigger points, these are elevated there. Okay? So if we put it together now, we can appreciate that whatever the cause, there may be some tissue inflammation by which you may release a number of biochemicals. This is just a small list, but these are some of the more important substances, right? Which can then activate a nociceptor, sending a signal to the dorsal horn of the spinal cord. But remember, we've got the dorsal root ganglion here, producing those neuropeptides which come back down, are released by the nociceptor. But what do? They will enhance the process of vasodilation, plasma extravasation. You're going to get more tissue inflammation, more sensitization, and you're going to increase the volley of afferent inputs coming in to the dorsal horn. Now, of course, when there's tissue injury under normal circumstances, we have wonderful descending modulation, right, which will help to dampen this, right, with glucocorticoids, catecholamines, helping to suppress this. But it appears that in certain chronic pain states, that process isn't working functionally well enough. And certainly, dysfunctional inhibition is a problem in chronic pain. But this is where I want to take you now into the dorsal horn, because now, if you have prolonged activation of these wide dendritic range neurons, you will lead to central sensitization. These are inhibitory neurons, which we'll talk about later, but that also help to quell the sensitization, the activation that develops here. But you can also see that segmental loss of inhibitory neurons, and we're going to be talking tomorrow in more detail about the facilitated segment and what can result. But here's the important thing to realize, that this is activity dependent, okay? So the more nociceptive inputs your patients have coming in from the peripheral tissue, the more likely you are to see this central sensitization developing. So that's why I often mention and emphasize to my students and say, look guys, as best you can, try to identify and eliminate any and all pain generators, whether they be somatic or visceral, because those will summate and those will lead to more and more central sensitization. So it's important to realize, as I said, that there's dynamic communication between the nociceptor and the central nervous system, the dorsal horn, and going in both directions. This is an old picture of our two boys. Here they're 3 and 5. He's now 6'2". He's about my height now. So that's time for you, right? But they're actually talking on their phone to their grandmother. But just showing you the communication, that it's, again, between the nociceptor and the central nervous system going in both directions, bidirectionally, simultaneously. So now this, one of the important things to realize, that no matter where the nociceptive input is coming in from, we're going to talk about this tomorrow, is that this can then, as I said, sensitize that particular segment, in this case if it's L4, all right, which will lead to increased activation of the anterior horn cell, the motor neuron, of L4 mediate innervated structures, whether they be in the paraspinal muscles or in the extremities, right? You will also see increased sensitization along the same dermatome, so they will develop sensitivity, allodynia, and hyperalgesia, as well as at the sclerotomal level along the periosteum, right? And you can also often see changes in the skin, whether it be through electrical skin conductance, signs of trophodema, etc. So one of the things we'll talk about tomorrow is how you can do a simple, a pinch and roll test to identify areas of allodynia. And I know when I had this first done to me, I kept turning around because I could swear my colleague was taking a serrated knife and cutting me around my segments between L3 and S1. And she said, no, I'm just doing a pinch and roll test. So patients often don't know. So the goals of my discussion for the rest of the session are to really get at what is the conundrum of myofascial pain, look at the unique neurobiology of muscle pain, initiation, amplification, and perpetuation of persistent sensitized states, review for you the emerging science of central sensitization and peripheral neurogenic inflammation and its relationship to the pathophysiology of muscle pain, and then show you that active trigger points of elevated levels of all those biochemicals that I told you about that we now know lead to persistent pain, sensitization, and local tenderness. So what is the conundrum? Well, as you know, and this group is certainly very well acquainted with this area, that these are very common, but they're a source of musculoskeletal pain, but they're often overlooked, right? And that's partly because we don't fully understand the pathophysiology. And also, there are no currently accepted criteria, whether they be biomarkers, electrodiagnostic findings, imaging findings, for diagnosing treatments or assessing the clinical outcome of treatments. To date, the physical exam is the gold standard. Your fingers, your hands are the current gold standard. But as I'm going to show you, we're now objectifying those findings that we feel with our fingers. Okay? So, what I emphasize to my students when I'm training is to carefully identify the top band of muscle, and then when you press on that exquisite trigger point, you can often reproduce the patient's symptomatic pain, and the patient will wince in pain, and they'll say, yes, that's it right there. And then many times, as you know, you can actually get a referral of pain, sometimes a very typical referral pattern, sometimes atypical. Not in Travell and Simon's book, because it's maybe atypical because there may be more widespread sensitization going on in that patient. And the current operative definitions, of course, are active versus latent. And an active trigger point is merely one that, based on the history and physical exam, you decide is associated with a spontaneous pain complaint. And oftentimes when you press on that trigger point, you can reproduce that pain. A latent trigger point shows all the same characteristics. It's hard, it's stiff, it's also tender, but it's not associated with a spontaneous pain complaint in someone without pain, or in someone with pain. It's a trigger point that's tender, but as you examine the muscle, you'll often find the patient will say, no, that's not the one, that's the one. Oh, yes, that's the one right there, right? Okay? So your patients become very, very savvy. They understand when you start searching for trigger points, which are the active ones and which are the latent ones, which are more active, which are less latent. I don't mean to suggest it's an all or none phenomenon either. There's certainly degrees of activity and latency, but that's the current definition. So if we just take a look at one type of pain, for instance, orofacial pain, you can see, again, the conundrum that is presented by trigger points. Depending upon the location of the trigger point, you can have quite a bit of overlap, and it can be a source of great diagnostic confusion to patients, to clinicians who treat orofacial pain. And of course, even the trapezius muscle, which is the muscle that we're doing our biochemical and ultrasound studies on, you can see has a quite unique referral pattern that can refer pain into the jaw. But what is often so common in patients with active trigger points in the upper trapezius is they may go to see 4 or 5 different types of physicians before they find someone who has actually examined their muscle and at least ruled out myofascial trigger points. They may see orthopedists, neurologists, physiatrists, you name it, before, and if no one examines their muscle, the diagnosis may be overlooked. Okay? So really, as you all know, in the U.S. we have, what they say when it comes to real estate, what's it all about? Location, right? Yeah, so when it comes to the real estate of the human musculoskeletal system, it's all about palpation. And I find it very, very interesting and very fascinating that, again, if you look through different systems of medicine, right, the Chinese have called these Shi points, and sometimes if you press hard enough, you can put a little extra letter at the end of that because it's exquisitely painful, right? You know what I'm saying? This is a G-rated lecture. Okay. The Japanese have called these kori or gummy, which is a loose translation for the head eraser on a pencil, right? The Germans have used the term Muskelharte, right? And so on and so forth. But really what they've talked about are these changes in the underlying density, right? And in this case, we're really talking about the nodule. So as you know, active trigger points can only be diagnosed by systematic palpation of the tissue. And there's no substitute for learning that, and that's what we emphasize to our students and residents. And if someone doesn't learn to palpate, unfortunately, the trigger point is often missed. Okay? So clearly there is that art of palpation, if you will, right? So what we try to do, of course, is think three-dimensionally. So if we can localize the trigger point, identify that it's active, then we can use treatments, whether they be needling or manual treatments, electrical stimulation, etc., to be able to deactivate that trigger point. The other common mistake that students make is they don't apply firm pressure, right? I worked with many medical students and residents, and so I often say you need to go to an expert at applying firm pressure. So if you remember from the Matrix movie, Agent Smith was examining Morpheus for trigger points in his suboccipital muscles. You see? Now, Agent Smith has really good palpation skills, and he identified the Morpheus' trigger points. What an excellent clinician. So again, you can learn something from the Matrix, okay? Remember to apply firm pressure. You all know that, okay? The other important thing is, it's very important to identify the right trigger point. I can't tell you the number of patients who I've seen who said, oh, I've had trigger point injections that didn't help. So I always ask them, well, did they carefully examine the muscle? Did they, when they put the needle in, did they elicit a twitch response, which we're going to talk about later? Yes or no? Almost always the answer is no, etc. So this little video just shows you the importance of identifying the right source of the problem, right trigger point. You don't have that problem here, do you? That's my life in the wintertime, guys. Helena and Vitaly can identify with this too. So, you know, you do all this, you're all great clinicians, you do all this work, you gotta identify the right trigger point, right? Okay. So we really owe a debt of gratitude to Trevelyan Simons, and as most of you, or all of you know, David Simons passed away. I went to his memorial service that was held in Covington, Georgia last year. But I find this quote from that he said so prophetic. Since no specialty, now he's referring to medical specialties, claims skeletal muscle as an organ is often overlooked. I know, of course, in physiotherapy, you folks live in muscle, but he was talking specifically about medical specialties. So he is coined the term orphan organ. So because no medical specialty claims that it's organ, despite the fact that it's 1/2 of the body by weight, there's no organized emphasis on muscle pain, in this case trigger point research and student training. So what happens is clinicians, including myself, eons ago, were taught to treat the symptoms of myogenic pain, but not necessarily the cause, which is often, but not always, trigger points, right? So yes, we can alleviate the symptoms by doing different things, whether they be medications, but are we getting at the underlying root cause of the problem and the mechanism of the pain? So, speaking of mechanisms and that, let's now look at what we're learning more and more about as it relates to what happens when there is muscle tissue injury, okay? So